Okay, let me check. Great, my mic's on. Well, thank you so much, and it's an honor to be here. It's an honor to be joined by my colleagues up here, and it's not quite an honor to have the dubious distinction of being the first speaker after lunch, but I'll do my best. So thank you all for returning, and look forward to this discussion. So I've been asked to start us off this afternoon talking a little bit about the triple aim. As Mr. York was explaining, we all have our own languages. And this morning, and the health affairs issue was really framed around this concept of the triple aim. And I know we have a lot of members of the audience today who are from the criminal justice system and may not be quite as used to the lingo and the language that we're using around this concept. So I'll start with a little primer on the triple aim, the concepts and how it's supposed to help us think about the challenges that we're discussing today, and then point out a few ways that in which the architects and the original thinking around the triple aim really was not grappling with some of the challenges that we're discussing today, but I think we can see our way through to folding these concepts into even that original idea. So, what is the triple aim? The triple aim was a concept, really an organizing framework developed by one of my former bosses, Dr. Don Berwick, who was also the former acting administrator of CMS for a short while, a couple years ago. And he and his colleagues at the Institute for Healthcare Improvement were trying to explain or develop a framework to explain why the U.S. healthcare system lagged so significantly in performance for quality and cost compared to other advanced economies. And they recognized that our healthcare system in general here in the United States had the following really system failures, as they called it. One, healthcare system is, well, I won't enumerate all of them, but I'll just highlight a couple. The system, the healthcare delivery system has classically been reactive. We respond to you in front of us at the moment of your need. Classically, it's had a short-term perspective. I'm looking at you now and trying to address what you have now in front of me. It also is highly transactional in nature for the same reasons. I get paid to look at you now and what you have now. It lacks memory. So before the major policy pushes of this administration in the past several years, electronic health records and patient registries were really not a feature of many healthcare systems, and so it lacked memory. And so people would interact with the healthcare delivery system and find that really we were not gaining an understanding of them over time. And we certainly had issues with understanding individuals when they hit different systems. And to that end, in the healthcare delivery system classically only knows what we know. We only know what has been in front of us or presented to us or our system, and largely lack the ability to see what's happening across settings, across organizations, and over time when individuals cross those boundaries. So the and finally, they were really identified from all these failures that the system really was in no way optimized to maximize care across settings and over times and across organizations. And we can add to that conversation today across sectors and across numerous organizations when they involve numerous payers with eligibility changes, et cetera. So the triple aim refers to a series of linked goals meant to be a dynamic, balanced set of concurrent goals that, this construct proposes that we consider simultaneously. Those three goals are the following. One is to optimize the health of a population, and I'll get into that in a moment. The population can be broadly defined. Number two is improve the experience of care. And they were really thinking about this concept of memory and service. The system knows me, it remembers me, it can serve my needs and maybe even predict my needs. And also minimize or get control of per capita costs. And so I like to think of the triple aim as a triangle floating on water, and when you push on one side, you're going to have impact on the other sides of the triangle. And so, some of the other efforts in healthcare delivery redesign over the past 20 years, let's say HMOs, for example, you might remember that, was really trying to push on the cost lever, and they really lacked meeting the other quality and experience goals, right? And that's kind of part of the brief history of why that didn't work out well. And so the authors are trying to suggest to us that we simultaneously think about any effort in the cost, experience, and population health domains. So what are the preconditions for pursuing the triple aim, especially for our population of interest? Well, the triple aim was the authors originally proposed that number one is you need to define the population. And in some triple aim work so far, largely the population has largely been defined as members of a plan, of a health plan. It doesn't have to be, though. It can be criminal justice involved populations. It can be the criminal justice involved population of New York or of Essex County. So the definition of what population we're trying to work on and optimize these other goals is first and foremost. And that can be done. And without doing that and getting specific about that, we can't then know things that we've been discussing earlier this morning, such as quality of care in the criminal justice setting and in the community setting. We can't know total costs of care, total investment in the social and justice-related and community-related healthcare sectors. So defining the population is number one. Can be done in many different ways. Number two is that there needs to be some sort of, in order to pursue the triple aim, there needs to be some sort of external policy constraint, meaning why would we do this? Basically an incentive. And oftentimes triple aim thinking says, well, maybe there's a per capita cost or a total cost of care, a total budget, that this population needs to be managed within a budget. And that would then incentivize the actors to do things like preventive care, what we were talking about this morning, preventive care, early treatment, effective urgent treatment, and ongoing supports and services to minimize cost expenditures while improving and investing in care all the way along. And then finally, they have this idea of the integrator, and this is really interesting, I think, for our group here. The integrator is an entity, a theoretic entity, that would theoretically accept responsibility for action on all three aims. So many times in healthcare and in the criminal justice system, we're sub-optimizing our own parts of the puzzle. And so this concept of the integrator is an entity that would accept responsibility to say total cost of care, the experience, and the health of that population is something that this entity would specifically take on to optimize, so that individual components are not being left undone or sub-optimized without the benefit to the whole. So what are some of the ways in which the original thinking around the triple aim might not have been thinking about the population that we're discussing today? First of all, we touched on this a little bit this morning. The population is one that can be difficult to define. Transient, highly mobile, changing. Even within the corrections setting, as I understand it, there's a lot of literal geographic transitions that one might encounter. We heard this morning that people incarcerated in one county might not be enrolled in that county. So if we're thinking about populations in this geographic construct, it could hang us up a little bit. Or if we're thinking about a population within the enrollment construct, we've also heard, and I think we'll hear also during this discussion, about churn and turnover, and also how can we know a person's in our population if heretofore they have never been in the population, as we were discussing this morning. They have been ineligible so far or out of the system. Now they're coming into the system, and just like the gentleman from the health homes in New York said this morning, there's issues with qualifying people to get into the system because there's no memory. So there are some issues, but we have a lot of good ways of defining this population, county level, membership in plans, et cetera. The other big issue, or a couple other big issues, and then I'll turn it over to Dr. Patel, are with total cost of care. And I think we all understand how enormous the societal investments are in the total cost of care of this population. In some areas, they're much too little, but in other areas, such as urgent and emergent rescue care, they're very high. But in order to make to have the integrator move care from the emergency room in the hospital, and really even the reoffending and costs of reincarceration, one needs to capture the full cost of care for these individuals and really quantify it. And I know a lot of good work has gone into doing that. And the promise of linking healthcare data through APCD and Medicare claims base with the corrections data, as was discussed this morning, is essential and vital work to get that done. And finally, as we were just discussing, with regard to this concept of the patient experience of care, there was an assumption, I think, in the original Triple Aim thinking. It was really about service orientation, that consumers would demand interaction with the healthcare system and would want the healthcare system to track, to predict, and to remember. I think, as we discussed in our article as well as in other parts of this conference, that is an assumption that we might need to work around and work with for this population, and understands that at face value that is an important goal, but it may not be as straightforward as Mr. York was suggesting, that people might not want to be tracked and remembered all the time for every interaction that they've had. And so we need to figure out, do some more thinking about how to achieve the experience of care that this population would consider to be value added, appropriate, and helpful for them. So thanks. I'll turn it over to Kavita.